Good morning. Congratulations to brave winds, but the big waves will not reach us. We are up. So it's my pleasure to open this session on hepatitis, and we will have several speakers from several places in the world, and we'll start with Adam CARRICO from Miami International University, who is going to talk on bio-comportemental actions, optimizing observance in the treatment of PrEP.
Can you switch to the microphone?
Yes, okay. Is it okay like that? So, Adam, you have the floor.
Thank you. It's great to see you all today. Je m'appelle Adam. That's the extent of my French, but thank you for bearing with me at my English. I'll be talking today on biobehavioral approaches to optimizing PrEP adherence in people who use drugs. This work is a collaboration with my colleague, Alexis Roth, and she is at Drexel University. So I'll be presenting some data from her team today, as well as my team. Just a bit of an overview on what we'll cover. I'll give you a nice tour of what we know about the PrEP care continuum in people who use drugs, and talk a bit about cabotegravir, CAB-LA, and its effectiveness in two large randomized controlled trials that have been conducted to date. And then finally, I'll talk about our work in contingency management, where we're leveraging financial incentives to optimize PrEP adherence, either with CAB-LA, the long-acting injectable, or with daily oral PrEP in people who use drugs. So thinking about the PrEP care continuum, when we look at people who inject drugs, one of the latest reviews by Bielo and colleagues in 2021 really shows us that uptake has been quite low. Around 0 to 3% of people who inject drugs have started taking PrEP. And so that is really the place in the care continuum where we're most focused in this high priority population. And then there's less engagement throughout the continuum. So even those that make it in to start PrEP are having difficulties adhering to it, remaining on it, and staying engaged in PrEP care. I will say too that there's a substantial heterogeneity among people who inject drugs that's not been well characterized. For example, only one of these studies that was reviewed in the article, the review article, was sexual minority men, or men who have sex with men. And very little work has focused on women who inject drugs. So we need to understand not only people who inject drugs as a large umbrella population, but the specific needs of groups within that large group. This is work from Alexis in Philadelphia. So we know that setting matters, right? Where we find people is always very important for how we deliver prevention programming. And largely, people who inject drugs are encountered, in the United States at least, at syringe service programs. And so what Alexis and her team did was implement PrEP care within a syringe service program, Prevention Point, in Philadelphia. So they had 95 women that were enrolled in Project She, so these are women who inject drugs. And they showed high rates of PrEP initiation. About 3/4 of the women who were offered PrEP started it, which was a great indicator of acceptability and willingness to start PrEP. However, after starting PrEP, daily oral PrEP, adherence was challenging. You see on the right here, this is urinalysis of tenofovir diphosphate. So they're quantifying tenofovir diphosphate levels in urine. And there was non-adherence in 3/4 of the participants at 12 and 24 weeks. And even those with some detectable levels had inconsistent adherence. So it shows that women really want to start PrEP and would benefit from it, but need adherence support through biological or behavioral approaches. And then persistence, or staying on PrEP, was 50% over 24 months. So about half of those that started remained on it. Another kind of important study that's being conducted in the United States is Integra, or HPTN 094. So this is taking kind of comprehensive one-stop syringe service programming with PrEP, MOUD, HIV/STI screening in remote vans. So, they're randomizing at the community level and having a mobile unit group that has this comprehensive services that reach participants in the communities where they reside, not necessarily expecting them to come into a brick and mortar facility. And they're comparing that to peer health navigation only, so referrals to traditional SSPs or other facilities. And then, of course, they have evaluations at 26 and 52 weeks. So Steve Chaptaw presented the results of this at CROI last year, and they found a 70% decrease in all-cause mortality, which is great, but no concomitant effects on PrEP use or viral suppression. So my hunch would be that this model is really reducing overdose deaths, opioid overdose deaths, and increasingly stimulant-involved overdose deaths, but not necessarily moving the dial on getting people to use PrEP or be virally suppressed. This was at the 26 weeks that they observed that mortality effect, which is astounding when you think about the rates that we need to observe a mortality effect in those happening within a 6-month period, essentially. It's shocking. So next, thinking about the PrEP care continuum in MSM or sexual minority men, it's a very different picture. We see the uptake has been quite robust, that MSM are very motivated to start PrEP. And so our review here from 2022, you see there's a very different representation of the numbers of studies, especially those looking at adherence and persistence on PrEP. And what we were able to do was look at the association of substance use. So within this specific population of men that are using substances, is there any evidence that it's associated with worse PrEP adherence? So we do see that methamphetamine is associated with worse daily oral PrEP adherence. But thankfully, due to many of the studies conducted in France and elsewhere, we see that 211 or event-based dosing may be a better solution for MSM in particular, that they can plan sexual events mixed with substances often and achieve prevention-effective adherence surrounding those events. So that's, I think, a bright spot in this. And we also see that not only stimulants like methamphetamine, but also cannabis, oddly, and other substances are associated with lower PrEP persistence. And so, more work to do here, but it really identifies, this population as one that would be benefiting from comprehensive prevention approaches that, emphasize 211 dosing, that optimize their daily oral PrEP adherence, and so forth. And we know that let's hope that goes good. We know that among MSM that sexualized drug use is the setting where we encounter this population. Much akin to the syringe service program with people who inject drugs. We see on Grindr and other geosocial networking applications that those are the places to find this high priority population and engage them in prevention programming or try and enroll them in prevention programming. Interestingly, there has become a coded emoticon language on these social networking apps where men are communicating their desires to have different kinds of sex and mixing it with drug use. So the dartboard for injection, the freezing man for ice, clouds for smoking, right? And flowers for people that are selling sex for drugs or money. So it's become this kind of robust kind of digital environment where drug use is managed, trafficked, and people meet romantic and sexual partners alongside that. So we have to think, shifting gears a bit, we know these populations are at higher risk for having difficulties with PrEP adherence and persistence. So what's the solution? What's the intervention? A lot of my work has focused on contingency management and a lot of our work in substance use more broadly, where we give conditional cash transfers, financial incentives. It goes by a number of different names, but we give small positive reinforcers, usually cash, for performing a target behavior. So the classic contingency management approach has been for non-reactive urine screens for substances. That people get cash as an incentive for being abstinent from that substance, at least during the past 3 days, right? And so this has been adapted for a variety of health behaviors, from maternal child vaccination rates to smoking cessation to HIV prevention. And we know that in people who use substances, contingency management is really one of our best evidence-based interventions, especially for stimulants where there's no pharmacotherapy. It achieves moderate effect sizes that are even more durable than cognitive behavioral therapy for reasons that remain unknown. But over here I have some of the neurobehavioral alterations that we see in people who use drugs, that they tend to overly value immediate rewards, right? This delayed discounting, that delayed rewards have a lower value. There's impulsivity in the mix and a preference for immediate rewards. So if we're able to provide those immediate rewards for behavior change, it changes the payer mix, hopefully, of their dopamine reward system and helps them see that there are immediate benefits to these potentially long-term behavior changes. And this really underscores why HIV prevention is so difficult, right? Because it is a longer-term consequence that's far distal in many instances from their immediate kind of behavioral satisfaction surrounding sex, drugs, or both. So the cabotegravir, when we're thinking about the biological approaches, CAB-LA is the, I think, best biological innovation that we've had in the past decade or so. So long-acting cabotegravir had a 66 to 89% slower rate of HIV acquisition, coincidentally better in cisgender women in sub-Saharan Africa. That was the 89%. And 66% in MSM and transgender women. But overall, we know that cabotegravir, compared to daily oral PrEP, is more effective. It minimizes the dosing requirements, obviously, and enhances kind of consistent drug exposure. But it's not without its own kind of needs in terms of medical management. You have an induction dose at week 0, a second dose at 4 weeks, and then regular doses every 8 weeks thereafter. So people need to come in for several different injections. We know that being late for a dose is particularly problematic because of integrase strand transfer resistance. This is a backbone regimen for many HIV medications at this point, and having an INSTI resistance is particularly problematic. And this is due to the long tail of CAB-LA. So it kind of wanes off and has a very long half-life, giving someone the opportunity to become HIV infected and develop resistance to that backbone regimen. Coincidentally, and I think shockingly, at this point it's 2025 and we're still excluding people who use drugs from these trials. People who inject drugs were excluded from the CAB-LA trials with MSM and transgender women, despite the fact that they're probably those that need HIV prevention services the most, especially I think about people that are injecting methamphetamine in the MSM population. So what Alexis and her team have done is a kind of demonstration project to say, we know that people who inject drugs were excluded from these randomized controlled trials. Let's see how we can do implementing it in the community setting. And so in this demonstration project, women are offered the opportunity to start daily oral PrEP on tenofovir, Descovy, or they're able to start CAB-LA. And women just have an incredibly strong preference for CAB-LA, the injectable. So you see down here, 9 people started oral PrEP and 128 started CAB-LA. Of those 9, about half of them ended up switching to CAB-LA. So, when women are given the choice and when we have those opportunities to give these, highly expensive yet very important prevention modalities, they choose them, right? And there were a variety of facilitators identified in qualitative work, such as co-located services, not having PrEP be separate from the needle exchange, separate from case management, for example. Financial incentives that our team and others are providing for PrEP, and having a supportive relationship with a provider that's non-judgmental and harm reduction focused. Interestingly, CAB-LA users, when we look at them, compared to the very small number of women that started daily oral PrEP, those on CAB-LA had greater odds of daily injection drug use and more sexual partners. So they were managing their behavioral risk by saying, I want to make sure that I'm adherent, right? That's at least our assumption. We can't say anything quantitatively with 9 daily oral PrEP users, but it's provocative. And similarly, you see these trends here on our survival curve, looking at kind of persistence, right? And so this is on the y-axis, PrEP adherence with sufficient protection, regardless of regimen. So 4 of 6, or 4 of 7, or 6 of 7 for daily oral PrEP, and then consistent CAB-LA protection. And you see CAB-LA is just really blowing it out of the water in terms of persistence and continuous protection. I would caution interpreting these, right? Because the 9 people on daily oral PrEP, it doesn't give us a stable parameter estimate, but it certainly shows us the feasibility of CAB-LA. When we move on to those that were receiving CAB-LA, an interesting kind of pattern emerges. And I title this No Magic Bullet, right? Because we can't think that we're just going to develop an injectable and all of a sudden the populations that we work with won't have issues like transportation, food insecurity, addiction severity that are barriers to their prevention needs. So in this, we had a contingency management protocol where they received financial incentives. We delivered that over the first 3 months of their enrollment in a randomized controlled trial that was alongside the community setting. And so they received an incentive, $40, $50, or $60, and a bonus if they were within 7 days of their target window, right? So it wasn't just getting the injection, it was getting it on time that they got extra money for. So they made $90 extra over time if they were in that 7-day window for each of their shots. And right here you see doses 2 and 3. This is a count, so the number of women in each dose. And you see that after the contingency management ends, there's a pretty steep drop-off. Although I would say this is a linear decline. It's not necessarily, I would say it's accelerating a bit, but we don't know if contingency management itself was responsible for, at least some people remaining on PrEP because it's not randomized in this design. And so being late here on the second dose, you see the green bars that are late people. That's 5 to 12 weeks. And then thereafter, it's 9 to 20 weeks. So within each bar, the adherence is relatively stable, but that persistence or the number of people remaining on PrEP is quite steep in its decline. And so this is very similar to daily oral regimens for PrEP and ART, where we talk about, remaining adherent and getting your dose on time, but also just sticking with us. And how do you stick with us? And what do we do to retain people in PrEP care? Our work has also focused on my team looking at remote contingency management for daily oral PrEP adherence. We use a cell phone application called Scene, where men log into their cell phones, they take a dose, a daily observed therapy, DOT, just like we do for TB and other chronic medical conditions. And they get small financial incentives for that video of a confirmed dose. We incentivize 4 doses per week, so they achieve prevention effective adherence for cisgender men. And we found that of the 303 sexual minority men that we engaged in the trial, all of them have problematic stimulant use, either cocaine or methamphetamine. 82% started this remote CM. So financial incentives work. They can engage populations that may not be engaged for talk therapy or other kinds of interventions. Sadly, we looked at reach as well, and those that started our contingency management program, this remote contingency management program, were more adherent on average, right? So the folks that had the most missed doses never stepped foot in our digital therapy that we were delivering. And so I think that speaks volumes to us about how we can reach folks that are at greatest need for HIV prevention. How do we get those folks that are really out there that are experiencing the most non-adherence, yet not responding to our financial incentives? Among the 82% that started the remote contingency management, engagement was incredibly robust. We had a median of 56 doses over the 3 months, so more than they and $340 out of 360 possible. And thanks for having me. This is a picture of Alexis and me. It's important, I think, like and enjoy the people that you work with, and I'm just very blessed to work with her and her team. We're moving forward with a couple randomized trials, trying to really boost and extend the benefits of contingency management. One is a trauma-informed approach for women, and the positive psychological intervention for men that use stimulants. Thank you.
Thank you. Questions? Next. Okay. Because I can hardly see the slide. So can you just see it? So who is doing prep here?
Microphone.
Who has experience with prep? Okay. Do you any questions?
Thank you for your presentation. Have you tracked adherence to other medications? Sort of the thing in my experience of taking care of patients like this is they absolutely take care of their PrEP, but it's all the other medications they don't take.
Yeah.
So did you use that as a surrogate marker?
We haven't. I know that, I guess in the pharmacotherapy trials they do, like the mirtazapine trials and bupropion with naltrexone, but it's a great point that, you know, many people have comorbid mental health conditions like bipolar disorder and, you know, where adherence is challenging, and it's something that we should be aware of more broadly. I do think men are more attuned to HIV risk, rather than even other general medical risks like cardiovascular disease that we see are so prevalent in context of stimulant overdose. And so it's that myopic nature of it is something that could be addressed for sure.
Maybe for easier interaction, we can have all the question at the end. So now we call Pascal MELIN, who is flagging for France, and he's working in Geneviève de Gaulle Hospital. Very few people know that in France. And Pascal just
Et Pascal,
teaching.
Merci Christian, merci à tous. Merci à ARGAITS et à Jean-Pierre de me donner la possibilité, comme tous les 2 ans, de venir faire le point avec vous sur l'hépatite B. Je travaille.
thank you. I work in Saint-Dizier, and I work as an addictologue and with hepatitis C patients. This is my conflicts of interest. We've been getting things wrong over the last 40 years. Everything's wrong because we should have the ATF, should be the name of the conference. We have to fight against fibrosis. I want to rip down all the posters on the way out. So it should be ATHS-2025. And I want to explain why. We've thought about the viral epidemic. UDIs are no longer a reservoir population thanks to the RDRD policy in France. The arrival of toxicomania is VHC is a limited epidemic affecting 60,000 people in France. The VHC in France, but there's no governmental study which has launched a study to say how much hepatitis C there is left. 20,000, 100,000. We need to propose a figure, say 50, 60,000 who live with VHC. I think it's a realistic figure. Here we should have been careful of Maïsol Touran back then. They said in they said that in 2025 that we will have eradicated hepatitis C. It's not the case, and if we don't get things moving, it won't be the case in the future either. So we need to reactivate these access to healthcare. Here we have, we can see how much access to prisoners care. For psychiatric patients, the arrival of new treatments has enabled us to have earlier care. We've gone from 64 days to 37. This is the shows you the screening. Hepatologists have. We can see there were 2 million tests which are reimbursed in France per year. These are laboratory figures. We haven't integrated the TRODs here. And we've got up to 3 million tests, and the number of cases of hepatitis C has fallen sharply. And the pharmaceutical industry say that there's under 4,000 people in France, but we're not testing them. Here, mortality, we say once the people have been treated, that's it. But if you look at what's happening here, when you look at patients with no treatment or treatment, virological treatments, you can see no treatment. There's a lot that die, though, who caught us again. But even after 5 years, there's over mortality. The fact that the treatment exists doesn't mean that everything has been solved. And we've abandoned the battle. Another study decided to show you is a German study, which is very interesting because in Germany they have registers. They know where patients are. So here they took just over 10,000 patients over 7 years. It's quite an interesting figure. And they looked at what happened to them. Survival with no events linked to the liver. If they had no, but look at what happens with cirrhosis. After 4 or 5 years, the figure is not the same. If we just let them, we discharge them, then they died of cirrhosis several years later. But we have to, so this is something we have to be very careful of. So, cirrhotics who've been have had their VHC, they get another illness, and they need to really be followed up. And so we need an echography every 6 months. We have clinical stamps, the absence of checks. Somebody who was 60, who was treated by a renowned. He was tested every 6 months. And 25 years later, he thought he'd been he would got completely better, but he hadn't. The consumption of alcohol after healing, drug takers, steps them back 10 years. In this group, 60% of patients consume more than 3 units of alcohol per day. I've treated their VHC, they're taking treatment, urinary tests are negative. And so they think that they can have a little bit of alcohol. And that's what we see on an everyday basis. I often talk about the driving license with points. Is this similar? If you have cirrhosis, then you lose points. If you have then treated for VHG, then you gain points. Weight gain after VHG healing. We have metabolic illnesses that are arriving now, and the message I want to get over to you is that we need to follow up the cirrhosis of patients with fibroscans and FAB4. Both are accessible in 2025, so we need to use them both correctly. Here are a few European studies, and you'll see that it's very impressive. You have here the states of fibrosis. One there's none, four there is. It's here you have fibroscan with classic probes. You have to have not eaten for 24 hours. If the patient has eaten within the 24 hours before the test, then it's not exact. Fibroscans under 8, exclusion of hepatitis C. In above 8, between 8 and 12, this is the grey area, and beyond 12, we can hear this is a cirrhotic state. Here's another way of presenting it to you. It goes up to 75 kilopascal. Under 3, you know there's very little cirrhosis. Above 3, it's pre-cirrhosis or cirrhosis. 14 is the kind of the upper limit. Here, this is where, if you look at testing in the general population, it's a Spanish study that wanted to be, was aimed to be European. 30,000 people. It's a huge figure. It was one of our Spanish colleagues who started this trial with chronic liver disease at the beginning. They had a fibroscan. It was based on it was on a voluntary basis. If there was a little bit of fibrosis, they were sent to a hepatitis center unit. This is from the general population. 0.8% of patients have more than 75 kilopascals. So 1% of the French population has cirrhosis. People who are pre-cirrhotic, 2.5%, and 4.6% people who started getting fibrosis. We're unable today. This is even more interesting. If you look at these studies, the fibroscan can be used as a prognosis tool. You can see over 3 years what the patients became. The more the cirrhosis, here above 25, here 15, the risk is liver cancer. It's a tool which tells you that above 2030, you have a risk of getting liver disease over the next 3 years. And prediction for global survival rates. Similarly, when you look at people under 9.5 cirrhosis, they're still there a few years afterwards. People who are above 50 kilopascals, it's 60% of mortality. It's a 5-year interval. These are, it's not something that happens every day, but these are urgent cases. The other tool, FAB4, you have it's a very simple tool, and which is retroactive, and you can see what happened before and what the situation is now. Below 1.3, there's no cirrhosis. It's more complicated above this figure. An American study, 20,000 patients between 2007 and 2018 with FAB4, 837 woman had hepatic events. If you look at where the patients are, for people who can be operated on for chronic illnesses, you can have a chronic illness even if FAB4 is low. So it's not a perfect tool. You have a survival with look at no fibrosis or intermediate fibrosis, and then as soon as you go beyond 287, there's probably severe fibrosis and life expectancy is very low. To say for the rate of problems, and this is something that's going to explode over the next few years. The risk of hepatitis events has been adjusted according to the sex, the use of tobacco, blood pressure, and the prognostic value is a super study. It's for people who are obese and people with diabetes. We evaluate them in the same way, a high FAB4, and as soon as you with patients with fibrosis, there are things that are happening in terms of hepatic events. 10. If here we can actually say how long people are going to live, we'll be able to predict by looking at their liver how they're going to live and the risk of cardiovascular disease. Here, all mortality included. You have the possibility and knowing what's going to happen. And perhaps people have been drinking. 10 years after severe hepatitis, this was done by our Swedish friends. Here they randomized if you had a high level of blood sugar, when it's in the abnormal blood sugar, the risk is 29, and that's enormous. This is general medicine. You don't need complicated IRMs. This is very practical. Here, Philippe Joan from Marseille, who looked at the entire population. This is there were 29,000 patients with FAB4 at 2.67, known for hepatitis, and those who are not known were sent an email, and here you get 3% of patients in this study. FAB4 men, doctors, a study was sent to the doctor, and 1 out of 4 doctors answered. So there's still a lot of work to be done for general practitioners to understand the advantages of FAB4. Masaldi, look what happens when you have if you have fibrosis as well, you have 3.4 cardiovascular accidents explodes, and renal complications, genital cancer, urinary, thyroid, colorectal, pancreas, stomach, esophagus. It's an inflammation which is going to generate, which can potentially create cancer. You have metalled. It's not the preferred music of Laurent Carilla. It's a mixture. The name comes from metalled. is in America is for obese patients and on cocaine, but we have people who drink quite a lot. They're not alcoholic liver patients as such. So we have quite a large group of patients. So we had to look at the classification. And here you have moderate alcohol consumption. Here you have a Japanese study and a Korean study. You can see it's metal. We have 5% of the population. Here it's much more. Between alcoholic liver diseases and between the two you have this intermediate space, which is going to lead to a number of questions. If we stop them from drinking having 2 drinks a day, or should we look at this status before? And if you're not convinced, this study, which is from 2019, which was done by the British, here you have the risk of liver disease, somebody with normal weight and didn't consume alcohol. The figure is 1. Overweight, here you have obese, twice as much chance of having a liver disease. If you look at people who consume alcohol, everybody knows it's dangerous for the liver. But here you have more than 2 glasses, and that takes immediately to 2.8. If you're overweight and consume alcohol, 3.6, and if you've got all of these, the typical French person who is overweight who drinks, the risk of hepatitis is 5.8 or more. That's something that should encourage us to look at the patients differently. I've almost finished. And here we see, if you look at liver cancer screening, you have hepatitis C, 385 cirrhosis, which were covered, and with an ecograph we get 41%, and those who use drugs, and they will have their diagnosis will be too late because they didn't get their ecography on time. So the average follow-up was 28 months, and the rate of mortality was 40%. It's a terrible figure. My final slide. We've been promised the arrival of AI would be able to alert us if you had something that had been prescribed. The figures 20 to 1. With AI, it's 1 case out of 5. And with this model, it enables us to reduce by 70% screening. It's our job is to rescreen people for hepatitis C. My conclusion is we shouldn't wait for AI to say what to do today. We need to think about that today. We no longer need to test for hepatitis C. We need to look at other factors as well. And our battle today is against fibrosis. It's not against cirrhosis. We have to do all we can to maintain our patients before cirrhosis. If we can't reduce the alcohol, we could get their weight down. And if somebody who is healed from hepatitis C and then starts drinking afterwards, we need a true strategy for these people. This will enable us to discover the severe hepatitis C cases. We need to stop screening everybody. Thank you. Thank you very much. We'll have a discussion at the end of the session, and we'll move on to our next speaker now, which concerns prevention as a public health perspective. We have Dr. Colom from Barcelona.
Thank you very much. It's a pleasure to be here for the Spirits meeting. It's a pleasure, an extraordinary pleasure. I'm going to be speaking English on
treatment, a public health approach. Je suis pendant beaucoup d'années le directeur de ces programmes. Ah, excusez-moi, voilà. Ici, on verra, this is the situation, the current world situation. Viral hepatitis and tuberculosis were the second leading cause of death. You can see hepatitis B contribute approximately of 254 million people, chronic hepatitis B, and hepatitis C, 15 million people. Hepatitis B and C are responsible for 1.3 of the million deaths a year. This is the projection 2014. You can see here the deaths from chronic hepatitis will exceed the combined mortality associated with HIV infection, tuberculosis, and malaria. We don't have anything. This is the projection in 2014. Why is it possible to eliminate the hepatitis C? Because we have two highly effective measures: HIV vaccination, hepatitis B vaccination, and treatment for hepatitis C. The treatment for hepatitis C is effectiveness, short, simple, once daily oral dose, almost no side effects, and now is cheaper. No treatment means cirrhosis and hepatocarcinoma. This is, as you know, the strategy of the WHO about the viral hepatitis. Challenge is to eliminate viral hepatitis as a public health problem by 2030. In Catalonia, we have a special plan, especially to the hepatitis C, in order to reduce the incidence, morbidity, and mortality associated, and also eliminate of the infection as a serious public health problem by 2013. This is the really important for us. Screening for all people based on risk factors, search for diagnosis patients, identification of vulnerable populations. And also, for all people, for all areas, test and treat in the same place, linkage to care, and simplification the procedures. In order that, we create in that moment the program that include HIV, STI, transmission sexual disease, and viral hepatitis, in order to planning, promotion, coordination, and evaluation the actions carried out in Catalonia to reduce the incidence of these infections. This is now our situation in Catalonia for general population. The prevalence of antibody is approximately 1.02, and the viremia is 0.5 approximately. But if we aggregate the population screened in primary health care during 8 years, the prevalence is obviously superior. The prevalence of antibody is 2.60, and the viremia is 1.59. But this is the other population very important for us. People who inject drugs, the more prevalence, 74 and 54. Drug users from drug care centers, people who go to outpatient centers. This is inferior, less than the other, but the prevalence is higher also, 23, and viremia, 8%. Co-infected people with HIV, people who are in prison, migrant people for countries with very high prevalence, and people who take sex and other men who take sex with other men, and homeless people. This is for us the principal population that we are very studied. What is the main change posed by viral hepatitis from a public health point of view is 4 strategies. One is undiagnostic infectious hidden cases without treatment. The second is the people who inject drugs. The third is the migrant people born in countries with medium or high prevalence. And finally, the people who are in the prisons. And also for hepatitis B, people born in countries with obviously high prevalence and without systematic vaccination. About the first challenge, undiagnosed infected people and hidden cases with diagnosis or biological markers, serology, viremias, without treatment. Here, for all people, promotion of a screening for risk conditions. We have a guide approved in order what are the 10 principal situations of you need to screening for risk conditions. And again, we implemented in all Catalonia the reflex test that is a very change of the years ago. And we have a GP, a personnel who was the reference in all GP centers, in health primary centers, and training for GPs and nurses. And 2 situations very particular are very interesting to explain you. One is, first is a retrieval of hidden hepatitis C cases, using the health databases for case identification. First is cross-referencing diagnosed patients with treated patients. You can here cross-match databases people with diagnosis during years and years. We match with people who are treated and also match with people who are treated before the appear of the antiviral treatments with ribavirin and interferon. This is the results. We find approximately 57,000 people diagnosed. And also we discover approximately 2,000 people treated without diagnosis in the database. There really is about all these people diagnosed, we have 34,000 people diagnosed and not treated. That means approximately, to distribute for all centers, primary health centers in Catalonia, 90 people for each center. And we try to do a pilot only in Barcelona city. Barcelona city has 52 primary health centers. We distribute, these people are diagnosed but not treated. This is approximately 6,000 people. These 6,000 people, the medical doctors are reviewed 84, 89%, 85%. This is the results. 600 people treated. That means approximately 12% of reviewed cases. It's a lot. It's very interesting. And this is we are very happy about these results. No? Now we deploy it to the rest of Catalonia. This is only the results in Barcelona city. The second thing is use of health databases for case in laboratory variables and inform each hepatologist to review clinical records. This is, in laboratory, identified last positive viremia without a subsequent negative viremia. We cross-referencing with the register of patients treated. Review clinical records in the hospitals, in the different hospitals, and the hepatologist inform directly at the patient directly or with GPs. We have different projects, 88 hospitals in Catalonia, in progress in 27 other hospitals, and we found a lot of people who are not treated and treated. The second challenge is high incidence in the people who inject drugs. As you know, the prevention are triple. Fourth is harm reduction programs like interchange of sharings, consumption rooms, education. Catalonia is very important in that. Opioid agonist therapies like methadone, buprenorphine, etc. And the high prevalence leads used to treatment as the prevention. Treatment of hepatitis C as a prevention. Two key approach. We have a protocol special for the people who inject drugs, but two key approach. Test and treat, and one-stop shop. Ideally in the direct care centers, in the same place where the people go usually. This is very important. In only one-stop shop, not 3 or 4 distribute, derivate to the hospital and return, etc. And this is the results. This is the cascade of hepatitis C screening and treatment in the outpatient centers in Catalonia. We screened approximately 7,500 people, and people, 23% are in contact with hepatitis C, 8% are infected, and of these, 75% are treated, and 75 I treat, yes, represent 70% of the infected, and 5% are cured. 75 are cured, and 5% are reinfected. This is a very, very interesting results. Very special in this elimination of people who inject drugs. The third challenge is migrant people born in countries with medium or high prevalence. You can see here that we have this screening and try to treat in the places and embassies, consulates, religious places, festivals, community centers, so on. The important is go there, no? Go is the possibility. And we test and screening hepatitis B and C and try to use the treatment there. Different populations, different situation, different Romanian people, Pakistanians, Senegal, different people are very prevalent in our country, in Catalonia. Here you can see the different interventions, practically 1,000 interventions in this year. More than 8,000 people screened and find people who are hepatitis B more than hepatitis C. And this is the medium of people who are screened in the health primary care. Only 22, 31, 18, and 14 people are screening different populations. That means we need go there with these different populations in situ, because the health primary care don't screening more than 18%. Finally, the people who are in prisons. Since 2016, exists a systematic rescreening on admission, treatment in the same center, in the prison, and linkage to community specialists on leaving the center, liaison nurse. You can see here on the right the decrease of infection, and now we can consider that the viremia is 0.09, we can consider eliminate the infection of hepatitis C in the prisons in Catalonia. We treat approximately 28,500 people in Catalonia during this period, 2015 and 12-23, and the main age is 54 years. And you can see here one thing important for us. The 25% of people that treated in the first time, the 25% in the first treatment are with advanced liver disease. That is very important to control that. No? This is the decrease of the mortality. This is an indicator by the WHO. They represent in 2030 we need decrease than 6, the tax at 6, the mortality, and finally hepatitis C, where we are treating fewer and fewer people because there are fewer and fewer people left to treat now. We must make an intensive equity effort to find the most vulnerable people and those with the highest barriers to access the healthcare system. No one can be left behind. Hepatitis can wait. Thank you so much.
Thank you.
And now we are going to the last talk, which is...
We're now going to hear from Jason Farrell from Amsterdam about reaching stigmatized chemsex users outside large cities.
Thank you. Good morning, everybody. Thank you for coming. And it's great to be back in Biarritz. So, my name is Jason Farrell, and I am the director and founder of Choices Support Center in Amsterdam. And today, I'm going to be talking about a project that we have to reach, I hate the word stigmatized, but we're reaching chemsex users outside large cities in the Netherlands. And unfortunately, many are stigmatized. So, Choices Support Center is a national community-based organization. We provide psychological and prevention services for people struggling with drug use and risky behaviors associated with drug use. And we work with asylum seekers and status holders living in the asylum centers throughout the country. Our services focus on the needs of the LGBTQ+ community, and we use evidence-based behavioral interventions tailored to the individual to support the minimization and elimination of substance use and related risk behaviors. Most of our clients and the people we see, particularly the asylum seekers, are severely affected by stress, trauma, depression, and insecurity to help them deal with their problems and improve their well-being. Our services are very low threshold and integrated. You can register on our website, or we have a free national helpline. The helpline is for the asylum seekers living in the centers throughout the country, and we'll be talking about the chemsex helpline. Everybody receives an intake assessment to determine the severity of their drug use and mental health condition to see if we are appropriate or they need to go into treatment or trauma care. The 3 pillars of our services include drug use behavior change, treatment readiness support, and migrant prevention services. Migrant prevention services include individual psychological and prevention counseling, weekly community building and social support groups, transgender care support to help many transgender people transition safely inside the camps, We provide this free psychological and buddy helpline, online psychological counseling and buddy coaching, empowerment project, and social integration initiative. The treatment readiness intervention was something we developed years ago at my clinic in New York, where we provided medical care for drug users around treatment adherence for HIV medication. The same interventions can be used to help people prior to starting treatment, designed to improve the treatment retention and outcomes. So by doing this, we help facilitate the readiness to change by identifying personal benefits and the barriers to change, and connecting people with other people who want to make the same lifestyle changes. So it's really a social network intervention as well. But today we're here to talk about drug use risk behaviors, chemsex. Some of you might know chemsex is the use of specific drugs before and during planned sex to make things a little more interesting. But some of the common drugs used are MDMA, GHB, cocaine, 3-MMC, ketamine, and crystal meth. Numerous studies have documented chemsex has caused the increase of STIs, and transgressive behaviors are concerned. A very clinical word. Yeah. So many engaged in chemsex don't perceive their drug use as problematic, but 1 in 5 men do seek help, based on studies out of the Netherlands. So when we first opened, 8 years ago, we provided a weekly social network intervention group and individual counseling. And this is for guys who could no longer manage their drug use, but wanted to make some changes in their drug use. Our treatment readiness services became very popular during COVID, because COVID, as many remember, we had a 1.5 meter social distance requirements, which caused a 50% reduction in people accessing care, and it doubled the waiting list. So people were needing help during this period. They came to us. We became very popular and well-known in the gay community. So due to the success of our free helpline for queer asylum seekers throughout the country, some guys involved in chemsex came to us and they asked us, can we use the helpline? And we're like, sure, but the people answering the phone, we have 10 psychologists, and each day there's a psychologist who speaks a different language, Monday to Friday. So you're guaranteed to speak to someone in your own language. But the team I have specialize in trauma and asylum seeker issues. So not necessarily chemsex. So if we wanted to do that, let's do a utilization study. Let's ask the guys in the community who are doing chemsex if this would be feasible, if they would like it. So we did that. So we launched a national survey targeting large cities, outside large cities in the Netherlands. Why large cities? Why outside large cities? Because our health department documented that 44% of men who tested positive for STIs in clinics outside the large cities engaged in chemsex. And this documented the prevalence of chemsex outside the cities. So our survey documented the gap in care outside the cities. 75% said there is a gap, there is a disparity in support services between urban and non-urban areas, and surprisingly, disparity was also evident in the STI clinics, with a disproportionate number in large cities compared to outside in less urban areas. So basically, if we were living in non-urban areas, it would be very unlikely we would access quality care for our chemsex problems. So when we ask, what are some of the issues? Well, 92% were not participating in chemsex services because they were non-existent. And 50% who did were not happy. They were not happy because many could not really talk to healthcare professionals about their problems, and within their own social network, many felt they were judged and not supported to minimize or abstain. When we asked about the free helpline, 68% said, yeah, this would be great. We could do this, but we would like an evening service and a national online support group. So we launched a national after-hours helpline. By implementing the helpline, we can ensure that individuals in urban and non-urban areas have access to necessary care. So the support requested included anonymous support by a psychologist or a former and current chemsex user. They wanted support and advice on how to talk to people about their chemsex, how to discuss different thought patterns around their chemsex use, support with trying to abstain, just someone to talk to, someone they could just, connect with. Because living out in rural areas, we found that many really couldn't talk to people in their own network. So what we feel is really great is by the community, for the community. We're trusted as part of the community. We are a community-based organization. The name Community Cares was chosen to help motivate unity and a response to help those struggling with chemsex and the risks. The growing numbers of people experimenting with chemsex that became problematic and whose lives have become turned upside down can be prevented. It's kind of like mobilizing the community to take action. And the days and times were recommended by the community, which is why it's called After Hours. So the project is more than just a helpline. Yes, the helpline provides a low-threshold platform for chemsex users to access care. The project provides an individualized and social network approach in prevention planning. The project empowers guys not only to address problematic drug use, but to reduce the risk of contracting HIV and other STIs. So what exactly happens? Well, we provide the helpline, we do triage risk assessments, individual cognitive behavior change therapy, and prevention planning, weekly social networking and prevention skill building support, and treatment readiness support, as I mentioned earlier. When we talk about skill building, some of the skill building we try to talk about and help people with include better defined and more objective risk perception through our personalized cognitive counseling. We try to help with skill development, how to work through skills and set up through these goals, through the context of prevention case management, and greater resilience and self-management due to a newly social network, support through a new social network. So what is prevention planning? Well, prevention planning is many of our clients come to us who can no longer manage their drug use but want to make changes. In a country where managed drug use is socially acceptable, those who can no longer manage their drug use feel inadequate and stigmatized. So despite this, many are ambivalent about making changes because many just don't know how. And we found that many need some guidance, a little push in the right direction. And so by providing the care, the psychological counseling towards behavior change, we're actually enrolling in a behavioral change intervention, which is what we do, and making a personal defined recovery, it makes it much more easier for people. So we assist with taking the first step in making a pragmatic personal prevention plan. And what happens is it's done together. Together, the psychologist and the client identify the barriers to personal goals, and well-being. In many cases, it tends to be the drug use and sexual behaviors. This is through a negotiation process. What's happening in your life? Why is this happening? So this actually provides many the first time where you could explore how drug use and sexual behavior and the frequency of sexual activities may have affected different aspects of your life. And this includes employment, vanity, sexual performance, relationship problems, health problems, and risk of sexual infections. When a prevention plan is negotiated and agreed upon by the client and the psychologist, that becomes the roadmap. The prevention plan includes pragmatic steps to achieve realistic, achievable goals. Together, they work towards reaching each goal by establishing actionable behavior change tasks done within an agreed time period. Clients come to choices, just some of the preliminary results, because they finally found a place that feels accessible. We're not too medicalized or mainstream. By helping our clients connect the dots, we're offering guidance and creating a mutually agreed upon personal plan. We minimize the anxiety to make changes. And the project thus far has demonstrated how an anonymous and confidential helpline is effective reaching people who avoid treatment or are unable to access treatment or care due to the lack of services, stigma, and lack of queer-friendly services in rural areas. And that's it. So, thank you. I have some information here you can take, and I'm happy to answer any questions. Thank you so much.
So now, since you are here, we are going to take the question to your talk. So, questions on this stigma of chemsex. Chemsex is very popular. Okay.
Thank you, Jason. Wonderful service and wonderful work. I'm wondering about connecting to Adam's presentation earlier about contingency management, and so I wonder if you have thought of using CM in your work and how that would translate into practical world. I mean, the research world and the practical world. Thank you.
Okay, I didn't hear that, the whole question. What, the whole question again? I'm sorry.
The question was about, have you thought about using contingency management in your work? And if so, how? Kind of linking the research world and the practice world.
How do we link the services?
Yeah. With contingency management in particular, the financial incentives for abstinence or for adherence.
Yeah, abstinence is not our primary goal. We are working with behavior change. So when we help people identify risky behaviors, they come to us because they have psychological problems and they want to deal with things going on in their life. Through the discussions, we help them identify what are the causes of some of these issues at the moment in your life. They happen to result from the drug use and the activities associated with the drug use. We're not telling people, you're not doing well now because you're using drugs and you need to abstain. No. We help people talk to us, and through the discussions with the psychologists, things come up. That's when we make a plan. And we help identify things that are things that are not going well in your life at the moment, and why is that happening? So through detective work, we figure out it's really because of the drug use and you going out every night and having sex with all these different people. Maybe this is something we should look at, and that becomes a goal to work on. So through a process of eliminating things that are going on, we help identify what is causing issues in their life. Once that is identified, we figure out through hierarchy of risks what needs to be minimized and eliminated. Now, if we find that behaviors need to be minimized or eliminated or directly associated with drug use, well, in some cases, the only way you're going to minimize or eliminate those behaviors is by minimizing and eliminating the drug use. You can't do one without the other. So we help people realize this, and they become more empowered to make those changes, which for many, they do minimize and eliminate their drug use at the end.
Yes. Please.
I'd like to hear you elaborate more on the differential needs of your migrant, refugee, asylum-seeking population to those of other populations you serve.
Yeah, the difference between, well, we work particularly among LGBT asylum seekers only. There are many organizations that help. We're not a refugee organization. We work with people within the queer community because they're most vulnerable. So imagine you flee a country because they want to kill you and persecute you because you're gay. You come to a country like the Netherlands and Germany and other countries to seek asylum. They put you in an asylum center with people from the same country who want to kill you and don't think that you should live. And these are your roommates. The trauma that you have already is exacerbated every day. So we help keep our clients mentally stable. We prevent them from killing themselves. We prevent them from getting addicted to drugs. We prevent them from getting sexual infections. We do this. We go literally into camps throughout the country. The camps that we don't go, we have a free helpline that they call. We work with the organization and the government that manages all the asylum centers in the country. They give us access, and we work with the staff in some of these locations. So we've been doing this for about 4 years. Every center in the country knows who we are. Residents in every center know who we are. We get calls every day from people throughout the country asking for help. And we go into 4 camps in 4 different municipalities. So the municipalities who fund us, we can go into those locations. Others we can't because, yeah, there are many. But the asylum seekers, there's two situations. There are asylum seekers waiting for their immigration interview, and then they're called status holders, where they get status, right? They become citizens. They have an interview, and they're granted asylum. They still stay in the asylum center, waiting years for housing. This is what the big immigration problem is in Europe, in many European countries, because there's lack of housing available. So even though I'm waiting several months for my interview with immigration officer, if I do become a Dutch citizen, I have to go back into that camp. I just get on another line, waiting for housing. But I'm still living in the same hostile environment. And so I have a different set of problems now. Now I get a BSN number, which is just like a Social Security number in America, and I could start looking for work. I start learning how to speak Dutch, but I'm still living in a hostile environment. So what we do is try to help people manage living in this situation, because we can't change that. So it's about accepting and coping skills, and connect them with social services. We also help many integrate into Dutch society and the queer community. What's very problematic is many will meet guys on dating apps like Grindr, and get invited to parties thinking that they're now in. Like, yeah, I'm cool, I'm in the community, I'm this thing now, I'm going to all these parties, but that's a very small percentage of the gay community. And what's the problem is that they get introduced to drugs and things like this, and that's become problematic. We try to introduce them to people in the real community through our social integration initiative, in which, as a Choices client, we have agreements with 3 clubs and bars in Amsterdam that let our clients in for free. So after 8 sessions with a psychologist, you get a Choices client ID card, and each week you speak to the psychologist about taking baby steps to integrate, because it's very overwhelming, the new freedoms. Going to a gay sauna in Amsterdam is something unbelievable for somebody from Syria or Uganda, right? It's just not possible. So for many people, it's about managing these new freedoms and not getting too caught up and, become chaotic. Sorry?
These camps are unique to the Netherlands?
No, unfortunately, the situation between the queer asylum seekers is common in many other countries where they put people in one building. And unfortunately, there are not many services available for this community in the camp. It's called, first aid, psychological first aid, right? And,
Okay, yes.
I'm actually wondering if you go to the asylum centers and try to raise awareness and social acceptance among these people for people from the LGBTQ community.
What was that?
Yes. I'm wondering if you go to the asylum centers and try to raise awareness and social acceptance for these folks to accept people from the LGBTQ community.
Yeah, so we only work with the community, the queer community in the camp. Luckily, the company that manages all the asylum centers, they've mandated an LGBT contact worker in each camp. That's our contact person. So if you and I were in a camp, we would see the LGBT contact worker there, and he or she will help look out for us. And some camps we organize our groups. Some camps that we can do individual counseling in a private room, but there are some camps the clients are just too fearful to be in a room together to be outed. They're too afraid to come out. There was actually a few locations where people were not just showing up. They were so afraid of outing themselves. So why the helpline? And if you don't have the privacy to talk on the phone, you could WhatsApp in your own language. You could text us. And we can't give everybody a train ticket to come to our office in Amsterdam, but based on a case-by-case basis, if you've been beaten up or traumatized, or you're a transgender person being stalked or whatever, yeah, you're coming to our office for a counseling session, you know. But if we ask people, do you feel safe and you want an appointment in our office, everybody's going to say yes. So we don't have millions of euros to buy train tickets for everybody. So next year we're hoping to have locations in different cities that are more closer to some of these areas. Because next year we're going to be providing treatment. We're now licensed by the country to provide treatment. And next year we'll be providing psychological treatment and addiction treatment.
Any other questions on this aspect? Now we can move to the two presentation with France and Barcelone, Spain. Any question on those presentation on the general scheme for fighting hepatitis C? So, do you have a question to the audience?
No, sorry, I have a question also for Jason Farrell about women in chemsex, engaging in chemsex. Do you give care for them also in your clinic, or is it more about gay community? Because in Belgium, we see that a lot of women are engaged also, but they don't find a room for that because it's really identified as a gay practice. And so I was wondering about your clinic. Also in heterosexual practice, they don't find a room for care. I don't know if it's clear or...
I don't understand what you mean. What was that? I'm sorry, my hearing is really bad.
No, sorry. No, I was wondering about women engaged in chemsex in your clinics, if you face this.
Yeah. We have not seen women, we see transgender women engaged in chemsex. There's a small group of transgender women. A colleague of mine did a study on transgender community involved in chemsex, but biological women we haven't seen. Also, now we are going, our buddy program is now also having a lesbian buddy because, so we're more diverse. So we have a trans man, trans woman, a lesbian woman, and 3 other buddies who speak different languages. So when you call, you connect with someone like you, right? There's a small number of lesbian women in the asylum centers seeking asylum. And many are from African countries, and some people also how horrible that they question if they're really lesbian because some have children. And some have children because they've been raped or they had to assimilate in their country to survive. So you had to get married and have children, and so now you come to the Netherlands and you want to be who you really are. People forget, people do what they have to do to survive in their other country, right? So, yeah, so the women, as in any addiction treatment, in low numbers, but we try to do our best to target women, yeah. I can get you information about the survey of transgender and chemsex, if you like.
So since we are in the hepatitis session, the impact of hepatitis on chemsex, you have not managed.
Yeah, well, surprisingly, we don't see much data on hepatitis and chemsex.
Because we have seen that in Lyon, there was a kind of epidemic of gay sex among male.
Yeah, there was hepatitis a while ago published, and a lot of reinfection among guys, but I haven't seen any new data on that. We do provide referrals to testing, and for those who are ambivalent or just don't want to go to the health department or fear, because in the Netherlands, you can go to the health department to get a free HIV test, but you have to meet the risk criteria. I have to be identified as a gay man with multiple sex partners. What's multiple sex partners? How many? And drug use. So, and there's there used to be, and they kind of minimized it, a severe questionnaire of asking you detailed information. So a lot of guys, they don't want to deal with this, and they don't go. Also, a lot of the asylum seekers were very fearful that a positive test result would sabotage their asylum. So for people who don't want to go to the health department, we offer them a self-test. We provide free HIV and Hep C self-testing, oral test. So if you do test positive, we can call our colleague at the health department, and you can go immediately to get confirmation and treatment. So, but people are ambivalent, especially the guys that we see outside the rural areas. Yeah.
I have one question for you about the cabotegravir. Cabotegravir, it's not active against hepatitis B. It's not function. It's not active against hepatitis B. For PrEP.
Sorry, I didn't get my headphones. It's not active for the...
Yes, it is active against HIV, but not against hepatitis B. So in the future, probably we could have a new infection.
Of course, there can always be adherence to any number of regimens.
Repeat the question.
Yeah, okay. So is it possible to kind of translate this contingency management approach to other medical treatments like hepatitis? That's the question?
Okay, well, we'll leave it for the break.
But I guess that talking on the hepatitis question, it's very controversial whether or not there's sexual transmission of hepatitis among gay men. We think that it does happen in the context of like non-vanilla sex, more for men with HIV, with a co-infection like syphilis. But there are very high rates of meth injection in the States and in Europe. About half of our participants report injecting. So in some ways, it's surprising to me that we don't see more hepatitis C, for example, in gay men or MSM.
Okay.
Yeah, and then in the Netherlands, our hepatitis C infections are pretty stabilized. Everybody has access to treatment. The biggest concern now is gonorrhea and syphilis.
Yes?
Since gonorrhea and syphilis were mentioned, I'll throw in, have you worked with doxyprep?
Yeah, it's definitely coming online. We see that when men, we have one study that's about starting or restarting PrEP, and guys send us a photo of their medication bottle as a contingency management protocol. So they get $50 for showing us they filled a recent prescription with their name on it. And oftentimes they're sending us both. So providers are explicitly giving doxypep and PrEP together. I think it's an evolving space, though, in terms of the uptake and risk of resistance and, you know, exactly how that's going to be implemented.
Yeah. And we have a national PrEP program in the Netherlands where people can access PrEP at the health department. Some asylum seekers can get it for free in some cities. And if you have certain low income, you can access the national program where you get a prescription for about €7.50 a month. And AIDS Funds has just refunded that initiative. So now it's available. So we're very happy about that. €7.50, it's great. And the guys in our after-hours project get a 10% discount at another provider for PrEP and testing, self-test kits if they want. So, yeah.
It's the same, sorry.
Go ahead.
It's the same in Catalonia. We have a very important program with PrEP. We are at approximately 50% of the people who take PrEP in Spain is in Catalonia. And we also incorporate, this is in the program of chemsex. We have a guide of chemsex, and it's also a risk, also by hepatitis, but by the other things. And we included the program of hepatitis also in the piloting program of chemsex.
also a PrEP is a very important strategy in that.
Okay, finally, before we break, have somebody experience with paying the indicators to get more of these hidden carriers? Have you ever experienced, because there are preliminary data suggesting it is very successful? You understand? Paying people who are going to send their friends to testing.
Send their friends for testing.
Yeah, and with a pay, some kind of a reward.
No, we don't give monetary rewards. There's no need.
No, but I just want, I'm curious because that's preliminary data suggests it works.
Well, testing, the health department goes and makes testing available for free, and anybody can get tested if they want, not a problem. For those who feel they don't want to deal with the bureaucracy or with the questions, they could go to different organizations that provide testing just for the gay community, or they could buy a self-test, or they can even get a self-test at the health department through the vending machine in the waiting room. So, access to testing is not a problem.
What's about you?
I think that when you think about financial incentives or cash transfers, we generally think of them as a motivator, like an extrinsic reward, but also they help people surmount structural barriers like transportation, food insecurity. So those incentives can be quite useful to engage people that are hidden or marginalized or not actively seeking services. Yeah, but I get your point that a lot of people are actively seeking out those services already. So like, is it a solution in search of a problem? And I think that's an important question to answer.
Yeah, I think for the magnitude of a problem, every option should be tested. And on these words, I thank the speakers for their contribution and the audience braving the winds. Thank you very much.
Thank you. I have some folders here in the front if you'd like. Help yourself. Thank you. It was good to see you again.
So sorry,